treatment of individuals with mental diseases. There's a state Medicaid manual provisions or guidance that go into detail about the determination of when an entity would be considered as an institution for mental diseases. And these are a few of the criteria that you may want to refer to in the future. So what are mental diseases? You take a very technical look at what would be included as mental diseases as those that would be listed in the current edition of the International Classification of Diseases and the Diagnostic and Statistical Manual of Mental Disorders, the DSM. Mental diseases, for this purpose, does not include intellectual disabilities, or to use the words of the state Medicaid manual, senility or organic brain syndrome. However, mental diseases would encompass alcohol and other chemical dependency syndromes as mental disorders. Now, there's certain exceptions to the IMD exclusion, and we're going to spend a little bit of time talking about these. And these are situations where Medicaid reimbursement is available for two benefits, two Medicaid-covered benefits. One is the inpatient psych services for individuals under age 21, and the other is inpatient hospital and nursing facility services for individuals 65 and over, and in an IMD. And these are the exceptions to the exclusion, and FFP is available for services in these categories. Sometimes we use a short form for the first category and call that benefit the Psych Under 21 benefits. Next, I wanted to talk a little bit more about each of these categories, primarily the Psych Under 21 benefit today. So again, inpatient psychiatric services for individuals under age 21. The Psych Under 21 benefit was added to the Social Security Act in 1972. It's an optional benefit, and prior to 1972, these services were provided only to this group in psychiatric hospitals. Uh-oh. Looks like my slides are advancing or going backwards mysteriously. But let me take control of the mouse here and see where we are. This benefit it can be found in the Social Security Act at 1905H. And it's important to note that the services under this benefit are inpatient services. And since these are inpatient services, ambulatory care would not meet individuals' needs, and the individuals must need the inpatient services as determined by a qualified team of professionals. Also, these services must be under the direction of a physician, and they must also reasonably be expected to improve a resident's condition or to prevent regression. My colleague, Peter Ajanama, is with us today and again can provide more technical expertise as far as the requirements for the facilities. They must be surveyed and certified and also credentialed by certain accreditation bodies. Peter, did you want to take a couple minutes and talk about some of the primary requirements?
Yes, thank you. My name is Peter. What Jean said about PRTF, there is another download PowerPoint that is attached, which you can look over to for references. So the PRTF has some requirements, which one of it is that the resident must be below the age of 21. In other words, if somebody is age 22, but the person is still in treatment, while the person turned age 22, the resident can still be in treatment. But there's a requirement that the treatment team must explain why the resident is there at the age 22. So another thing is a resident who is above the age 22, a resident who is above age 22 can also be transferred to a regular psychiatric hospital if the resident still need the treatment. The psychiatric residential treatment facility can be established in a hospital, in a regular hospital, or it can be a standalone facility. When it's a standalone facility, it must have its own physician and also psychiatrist. Most times there is a lot of question that comes up about if a physician can take care of one facility and at the same time also be a physician in another facility. And the question is yes. There is no regulation that a physician must be a permanent physician for a particular PRTF facility. So a physician can satisfy a PRTF and at the same time provide services for other facilities. So Jean already said something about who may receive services. A participant for PRTF must be an inpatient psychiatric services, and there must be a physician who will participate as a member of the treatment team. You know, the physician don't need to be a full-time physician, don't need to be a full-time employee of the PRTF. As long as the physician is available to control and manage the treatment team, and also perform other services of the physician, such as giving the order, and also providing assessment for admission and discharge. So, physician here can be a medical doctor or a psychiatrist, or it can be anybody that is licensed as a medical practitioner. So there is other staff requirements with regard to the treatment team. So we have to look at that. But with regard to nursing, there's a requirement that PRTF will have nurses who are staff. And this requirement is very important because the nurses are the people that do the assessment in the PRTF, and also they receive doctor's orders and manage the milieu. Also, there's a requirement for psychologists and also for social workers. So these staff requirements are, depends on the components of the services the PRTF provides. What is most important in the provision of services is that the PRTF will have a treatment team that is dedicated to the services of the PRTF. The treatment team must have a physician and also a psychologist. The psychologist requirement, the psychologist may be a master's prepared psychologist or a doctorate prepared psychologist. The requirement is that the psychologist must be a clinically prepared psychologist that have experience in mental health treatment. So I'm going to turn this over now to Jean to continue. Thank you.
Great. Thank you, Peter. That was very helpful. And again, just wanted to alert the listeners that many of these guidelines are in the attachment to your webinars for future reference as well. But before we wanted to go on much farther, I wanted to talk about provide maybe a case study or a profile of an actual person who's received PRTF services. We were fortunate a few years ago to have award grants to 9 states so that we could better understand who receives PRTF services. And this was through the Community Alternatives to PRTF Services demonstration program. One of the states was Alaska, and it was particularly interesting to me to hear about one young person's experience, because a while back when I first came to CMS, I became aware that there were young people in Texas who were actually from Alaska, and they were receiving the residential treatment services so very far away from home. So that raised some questions for us. And also it was very troublesome for the state and the individual that one of their young people had to go so far away to receive the services that he needed. But we'll call him Tony, and he had, like many young people in a PRTF, significant impulse control issues. His behavior was many times aggressive. He easily became violent. He disobeyed authority, got in trouble at school and also with the law. He received family therapy. It didn't help. He had many diagnoses, but one was included fetal alcohol syndrome. To further complicate matters, his single mother was totally overwhelmed with Tony, and was also trying to deal with her own addiction problems. So it was decided that he really needed inpatient treatment to address his numerous significant issues that were rising to a level of risking harm to others. As I mentioned at the time, Alaska had no providers to meet the intensity of Tony's needs, and he was sent to a residential treatment facility in Texas, where other Alaska children had also been sent. It's unclear if this residential treatment facility at the time met the requirements listed on the slides, and that Peter so nicely outlined, because Texas does not actually cover PRTFs. CMS Survey Insert subsequently, just a couple of years ago, issued a memo describing our expectations and requirements for this kind of scenario where you have someone sent to another state, where it is now expected that those facilities meet Survey Insert requirements at this time. But anyway, long story short, subsequently the state was working really hard with addressing this issue, and they launched a program called Bring the Kids Home Initiative in order to return children from out-of-state placements. And this resulted in the state developing their first certified PRTF. And it also launched a package of community-based services to support the children when their need for PRTF services ceased. And more importantly, to divert the need for that kind of inpatient stay to alternative services. This next slide addresses some of the services that were found to have really made a difference to the individuals when they return to the community. Actually, this is a slide includes many services, but the ones that were particularly helpful were targeted case management services or wraparound services that help to create a plan and connect Tony with any needed additional health, education, or employment services. In addition, Tony's mother received referrals and treatment to address her continuing substance use disorder issues. The demonstration also made available respite care to families who are dealing with some very significant behavioral problems, and a respite from the constant ongoing stress of caregiving was so valuable to them. The other service that also the demonstration showed made a difference was providing peer supports. That is someone who is a peer who had experienced similar kinds of issues, working under the direction of a qualified behavioral practitioner, health practitioner. to help implement that treatment plan to one of the peers. So all of those services are coverable under Medicaid, perhaps through the traditional 1905A services that you see listed on the left-hand side of the slide, or through the other Medicaid authorities as well. And just a couple minutes on these services too. Section 2703 is health homes, and this is a very comprehensive service in order to provide needed case management and coordination for individuals with chronic conditions. And one of those chronic conditions could be mental health and substance use disorders. We found that many states choosing this option have decided to focus and target their efforts on health homes for individuals with mental health or substance disorders. 1915I is another category where reimbursement is available for more of the non-traditional services. It can also make a difference as far as easing the transition from an institutional situation or to actually prevent exacerbation of certain conditions. I had mentioned respite care earlier on, and this would be the kind of service that would be coverable under 1915I under state plan home and community-based services. I don't want to forget our alternative benefit plans that are meet the needs of the new adult population, and the research isn't in yet because we've launched those, of course, in 2014. But this comprehensive list of essential health benefits and other additional services to meet the needs of the new Medicaid adult population can really make a difference, again, to providing needed mental health and substance use disorder services in parity with other services that are essential health benefits. We're hopeful that by making these services available to all of the family members of individuals like Tony will have better access to the care that and services that they need. Section 1915B, also listed on this slide, again uses a managed care. May use a managed care concept to identify a particular provider to better coordinate care, to provide care more efficiently, as well as to make available services that are additional healthcare services beyond those that could be provided through savings generated through managed care efficiencies. It provides a little bit more efficiency to meet the needs of individuals with mental health and substance use disorders. As well as Section 1115 demonstrations, which are designed to really test some new concepts to meet individuals' needs. And again, several that are off and running again can provide not only the traditional benefits and the new configurations, but additional kinds of benefits that can be helpful to enable individuals to continue to reside in their communities. So with me is John O'Brien, our policy advisor, and there's a few other opportunities and options that he'd like to tell you a little bit more about.
Thanks, Jean. So in addition to some of what Jean talked about in terms of the other authorities, we're working closely with our other agencies, both SAMHSA and the National Institute of Mental Health, to try to message some services that are much needed by those children and youth that have experienced the first episode of psychosis. And similar to the informational bulletin that we put out 2 years ago that highlighted some of the benefits that Jane just talked about, we're going to put out an informational bulletin that will talk about some of the critical services that subgroup of youth with significant mental health conditions can benefit from and that have been well researched. In addition, you may or may not know that we've been working closely with SAMHSA on a demonstration program. It's called Section 223, or it's the Certified Community Behavioral Health Center program. And we are making available to both states and tribes the opportunity for the states and tribes to explore the possibility of creating a network of certified community behavioral health centers. And we have, I believe, a webinar tomorrow, and Kitty, I can get you the information that folks can listen to regarding a request for application for CCBHCs. So those are the two opportunities that are going to be imminent over the next several months, and we just wanted to highlight that as part of this conversation as well.
When we were planning the webinar today, one thing our partners mentioned, and I almost forgot, but I know that many of you are providing services in very rural areas, is that the technology has been so there's so many improvements in technology that many providers are using telehealth in order to deliver services in rural areas and other areas. And again, this is a service delivery mechanism that for which services may be provided, and very useful and helpful for getting expertise out to rural areas to many benefits. And that is about it. I just wanted to finish my remarks today with letting you know that we're always interested in getting your questions. Our names and email addresses are provided on this slide. But I also wanted to make you aware of our structure within CMS. Of course, state Medicaid agencies are operationalize the Medicaid program in each state. Each state's a little bit different, so it's really critical to understand how Medicaid is operationalized because every area is quite different. The other piece of that is CMS has 10 regional offices. And again, there are tribal liaisons in each regional office that you're probably already familiar with, but the regional offices are just a wealth of information to you, particularly with knowledge of the state Medicaid programs within their purview. And I'm sure they would be happy to talk with you further about any payment eligibility or coverage issues. But in central office here in Baltimore, again, my division is very much involved with benefits and coverage. So any questions you might have as far as what does Medicaid cover, I'd be happy to hear from you as well. So with that, I will turn the session over to our moderator or operator.
Thank you. If you'd like to ask a question, you may do so by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute button is turned off to allow your signal to reach our equipment. Once again, it is *1 to signal for a question or comment at this time, and we'll pause for a moment to settle the queue. And once again, it is *1 to signal for a question on the phone. And it looks like we have no questions at this time.
We do have a couple of questions that came into the webinar interface. The first one is, for the substance abuse disorders in the community, is this only for those 21 and younger and 65 and over? And even in Medicaid expansion, even in a Medicaid expansion state?
I'm sorry, this is Jean. I'm sorry. Could you repeat the question again? I didn't catch the first part of it.
Sure. For the substance abuse disorders in the community, is this only for those 21 and younger and 65 and over?
Okay.
And is that even in a Medicaid expansion state?
Okay, there's a lot in your question, so let me step back a little bit from that. looking at traditional Medicaid, services to address mental health or substance use disorders services are many times covered under rehabilitative services category or through licensed practitioners or, of course, through an inpatient benefit for those who would need it. So that's kind of the standard benefit. The substance abuse and mental health disorders are optional services, though. And if you look at a state plan, or if you go to the Social Security Act, you're not going to see those words called out. But I just, if you're interested in knowing what your state covers as far as mental health and substance use disorder services, I'd suggest that you take a look at their state plan. And that state plan is a document. It's hundreds or maybe even 1,000-page long that describes how a state operationalizes their Medicaid program, eligibility, payment, and services. And if you dig far enough, you'll be able to find out about the coverage for those services. And most states put their state plans on the web. But certainly, that if you want to go through that research, otherwise you're contact the state Medicaid agency, and I'm sure they would be able to better describe how the state administers those services. So that goes on to the second part of addressing your question, is services are covered in many different ways through many different service delivery mechanisms. It could be fee-for-service through just a qualified Medicaid enrolled practitioner in the community. And many states use managed care. The state will contract with a managed care entity in order to be a provider or to develop a network of providers in the community that the managed care entity would enlist to provide those services. So it's really important to understand the configuration of Medicaid in the different areas. Moving forward, you would ask about alternative benefit plans. And again, in states that are expanding Medicaid, mental health and substance use disorder services are an essential health benefit. And so these services, they're not optional like they would be under the regular state plan, but these services would need to be provided to anyone in the new adult group.
Right, but the whole, I'm sorry, this is Nancy Kirchner just chiming in, but the whole Medicaid expansion and the alternative benefit plan is an option it's a state choice in terms of being able to do it. But if you are going to do it, you have to provide all of the essential health benefits, and the ages covered in that new adult group would be from 19 to 64.
Okay, so they fit very nicely with our other ages that we've been talking about.
Except for that 19.
There's a little bit. Yeah, there's a little bit of an offset there at that point. So does that answer your question?
I'll see if they have any follow-up questions or comments coming through the webinar. Our next, we have received several through the webinar. The next question is, what is the reimbursement rate, and is it the all-inclusive rate?
Well, I tell you, you do not have the payment experts on the phone today. So, again, if you'd like to send us a note or a question, we'd be happy to take your email, and we'll forward it to our payment experts.
Right, and this is Kitty Marks. We might need to, because they're referring to the IHS encounter rate, and so maybe we can follow up with IHS and follow up with this person asking the question as well. Thank you.
That's a good idea.
Okay, the next question through the webinar is, are there different state designations?
I guess I'm not quite sure I understand the question.
So maybe if the person who submitted that question, if you could submit some follow-up information through the Q&A box, we might be able to answer it.
take a stab at it, though. The state Medicaid agency and the state Medicaid agencies are called many different things. There's kind of catchy names throughout, but every state does have a single state agency that would be administering the program and is responsible for the provision of those services. And again, our regional offices can help a lot with pointing in the right direction.
Gene, some of it may be the designation or the nomenclature of a particular facility, and so there are states that may call psychiatric residential treatment facilities a different name, but they would still have to meet the psychiatric residential treatment facility standards. So there are a couple states that have accredited residential treatment facilities, and those accredited residential treatment facilities have to meet the PRTF standards. So there may be, again, depending on the state, different nomenclature for these facilities, but they all have to meet the PRTF standards.
Great, thank you.
And we did receive confirmation from the first question that did answer their question, so we're good there.
Great, thank you.
The next question we have is, what other inpatient services has the Secretary approved for funding from Medicaid that is not a PRTF?
Well, the benefit, the coverable benefit under Medicaid is the inpatient psychiatric services for individuals under 21 benefit. And so there's three settings where this benefit could be provided. We talked a lot today about the community setting, the psychiatric residential treatment facility setting, but certainly these services are available in a general hospital and also a freestanding psychiatric hospital too under this benefit.
Thank you. The next question we have is, who determines if a facility or institution is an IMD or not?
Well, when there's a question about is a service an IMD or not, we see it as a state responsibility to make sure that claims are not submitted for services in such facilities. So ultimately, it would be the state identifying when it would be appropriate to submit claims or to receive reimbursement from Medicaid for those services. Now, I had mentioned the state Medicaid manual, and on these slides is the reference of the section that is available on the web. So that would be the criteria that we would suggest that the state would use in order to help identify what would fit in this category.
We have a follow-up question to that. What category do you consider the RTCs to be?
Residential treatment centers? Is that, I imagine that's what you're referring to as an RTC.
If the person
I just wanted to start off and saying that when we're talking about the IMD exclusion, we're talking about a payment exclusion rather than a particular type of facility or center. In Medicaid, we think of inpatient facilities as entities such as hospitals or in intermediate care facilities or nursing facilities, or inpatient psychiatric facilities for individuals under 21 would be, again, those kinds of facilities. Under Medicaid, we don't have a specific definition for a residential treatment center. However, when you do have a building or facility that has more than 16 beds and is primarily for the treatment of a mental disease, it would fall within that IMD definition. So, and again, it could fall within the IMD definition, and there's those two exceptions that we discussed earlier today for the inpatient psych under 21 or the over 65 and over benefit categories. There are facilities that are 16 beds or under that I'm sure you'll see are residential treatment facilities, and we would not consider those to be IMDs or subject to the IMD exclusion. And then they would be certified or classified, however the state may wish to license such centers. It would vary in that respect, and payment could be made for discrete services that are provided through those residential settings if those services met Medicaid requirements.
Great, thank you. Next question. How many tribal/IHS facilities have 16 beds for MH?
I'm sorry, I don't know the answer to that question.
Yeah, Jean, this is Kitty Marks again. I'll take a note for that, and then we'll have to. That's an IHS question. I don't know the answer to that either.
Okay.
We'll follow up with the person. We'll follow up with Ruben asking that question. Thank you.
Okay, next question. Due to EPSDT, I thought children had coverage for any Medicaid service, but they don't have access to PRTF unless the state opts to. How do these fit together?
That's a really good question. Ultimately, they do fit together, and individual children through the EPSDT comprehensive benefit are required to have access to any needed services. So although we say it's an optional benefit, it ultimately is required that children have access to inpatient psychiatric care. It's a choice of the state and also up to their capability, though, as far as if PRTFs would be available. In fact, and Peter or Don, you probably know the answer to that. I believe that there's about 360 PRTFs. Is that about right?
Yeah, this is Peter. We have 384 PRTFs. And adding to what Jim said, if the state didn't opt for a PRTF, there's a requirement that the state would either meet the mental health needs of the client, either through the ordinary hospital or psychiatric hospital, or by transferring the resident out of state to the state that has PRTF. In fact, we have a lot of states that move their residents to another state for the purpose of treatment. So another thing is the individual under 21 can also receive treatment at the community mental health centers. So that's another.
I think you're suggesting that one slide, the next to the last slide, provided that listing of all the possible or many possible options of Medicaid coverage categories where mental health or substance use disorder services are provided through. Again, you'll notice, and these are, I believe, for the most part, the services on this list are all would be considered outpatient types of services, and reimbursements available. And I think, Peter, again, just to build on what you've mentioned, many times we do have federal qualified health centers that provide a lot of treatment, as well as I'm sure the tribal health centers also would be a great resource for providing such care. Rural health centers.
Okay, and we only have about 10 minutes left. If we want to go through some more questions.
Okay.
Great.
The next question is, are these benefits available for individuals who have aged out of state and tribal foster care systems up to the age of 26 who are now eligible for Medicaid coverage?
The services would be available to individuals, and it's going to depend on, again, what the state provides in their state plan. So for the most part, these services would be available to anyone who meets the eligibility criteria within that particular state. I believe that you're probably interested more in learning more about the group of individuals who are aging out of foster care, and that would be a great question if you could send that to us. There's an informational bulletin, or maybe it's a state Medicaid director's letter that really explains the eligibility for that new mandatory group of young people who are in foster care, and where that group would be eligible for Medicaid through age 26. But the informational bulletin provides a lot better technical detail than I'm able to provide today. So again, if you could send a note to us, then we'd be happy to get that information off to you.
Okay, next question. What counts as inpatient services? Does it relate to having an actual physician order indicating inpatient status?
Right, and for Medicaid, inpatient services would be services provided to an inpatient over 24 hours, and payment is available for a Medicare covered medical institution.
And then the next question, if not designated as inpatient status, residing at the IMD and receiving services, can Medicaid funds be used?
I think I'm hearing that an individual is residing in an IMD, and the only exceptions would be for the individuals receiving the inpatient psych under 21 benefit, or for the individual 65 and over.
Okay, and the last question we have in the queue at this time is, does a substance abuse disorder fall under a mental health disorder and considering Medicaid reimbursement?
Yes, it does.
And that was our last question.
Great. Well, again, it was a pleasure for us to talk with you today, and we look forward to hearing your additional questions. And thank you, Kitty, for pulling us together.
Yeah, thank you, Jean and John and Peter, for your participation on today's call. And thank you, Martha, for being participant as well. And we do want to thank all the participants for your questions. I think they were very good questions. And so we will follow up. Our office in the Division of Tribal Affairs will follow up on the IHS issues. And as part of the slide pack, we do have Jean's and John and Peter's email. So if you have any questions, please feel free to contact them. These PowerPoint presentations will be posted on the CMS, American Indian Alaska Native Outreach website page, and you can reach that. Let me give you the direct link. It's go.cmS.gov/A, And so you'll be able to pull down these PowerPoint presentations on our website. It'll take a few days to get them posted. And as always, if you have a question or a follow-up from today's call, Division of Tribal Affairs maintains a mailbox at tribalaffairs@cms.hhs.gov. And again, thank you, everyone, for participation on today's call. Have a good rest of your day. Thank you.
This does conclude today's conference. We thank you for your participation.